Hi, my name's Andrew Van Lint and I'm a medical registrar. And I'm here today to talk to nurses about phoning a friendly doctor and how to be prepared for that phone conversation. And just in case you're wondering if I usually wear such a loud shirt, it's Friday and I like to practice floral and fun socks Friday. So I encourage you to do the same if you're not required to wear your usual uniform. So before you have any kind of phone call, there are three really simple questions that I want you to consider before you pick up that phone. One is, what is the purpose of the phone call? What do you want to achieve in terms of the outcome of that phone call? Number two, what's the information that you need to be armed with, either that's before you on a chart or on the computer, or that you've memorized briefly before you make the phone call? And third, who is the person that you can call who is most likely to achieve your goal? So those things again, what is your purpose and desired outcome? What is the information that you need to achieve that? And who is the best person to achieve that goal? Those are three simple questions that would really help set up a great phone call. And just considering them for a few seconds before paging is a really good way to go. So let's talk about who you might call at different situations. And really, there's three kind of categories I think of in terms of timing. So the first is the working hours period, which is usually Monday to Friday, 8 till 5. This is when we have maximum medical staffing, that is in terms of doctors. Most consultants are present during that time. Most registrars are present during that time. Interns, residents, you've got a lot of options during working hours, and that's great. And so that will usually be that period. And then kind of a similar thing on the weekends from 8 until 11 or 12, you will have representatives from each home team that has inpatients. You won't have the full spread, but you'll at least have someone that has the continuity of care for those patients. The next category is generally after hours, and these are kind of daytime hours. So from 5 until 9 p.m. on weekdays, and then from about midday until 9 p.m. on weekends. And these are times where you've got cover in effect. You still have often the same doctors that are on the team looking after the patients, but there's a lot of things called cross cover where someone who is not usually responsible for those patients will be the person that is first to call. You won't have as many options in terms of who do you call during those periods, and so it's just important to know, okay, 5 o'clock has changed over, I can't call the regular team, let's check the roster or check my local records to say who I should call this time. The last period is the overnight period, and that's where we have minimal medical staffing. You can think of it like a skeleton crew. Certainly in terms of nursing, we have similar kind of reduced staffing overnight. And for doctors, this is between 9 p.m. and then 8 a.m. the next morning. And at this time, there really is minimal options. You'll have allocated an intern or a resident, and the main escalation is to a registrar that's on site, and rarely to an off-site registrar or consultant. But that's not usually something that you would, as a nurse, be expected to do. So those are three categories: working hours, after hours, and overnight. In terms of who you might call during whichever period, and that's guided by which time of day it is, the first person you might go to call is an intern. The intern is fantastic for understanding what's going on with the patients and getting those really short tasks they're doing. So unusual observations like BGLs that are high or low, blood pressures that are high or low, heart rates that are high or low, saturation that's dropped. The intern is your first port of call if your team has an intern. They're also the first point of call if you need bloods, because maybe they're on a heparin infusion and need an APTT, maybe they need an INR to inform their warfarin dosing, maybe they're post-op and they need to have some bloods like a CBE and biochemistry sent. Your intern is the person to call. Likewise, if they need IV access like a cannula, the intern is the first person to call. So if you're thinking about observations, you're thinking about bloods, you're thinking about medication changes, you're thinking about IV access, call the intern if there is one. Many teams, particularly specialty teams, don't have an intern, and so you'll call the resident for that same type of role. The resident has some unique responsibilities, so they may still do that, or complex issues within that intern kind of domain, and there's certainly some of the intern can escalate to. The RMO has some really unique roles and responsibilities. Two of them are RDR modifications. So if you need to make a modification to a patient, you know that they're well, this is an expected observation, but it's technically outside of range. Interns can't do that, so you need to call your resident. And don't even bother asking the intern unless you know that that's the person to escalate those things to, and they'll get a resident to make those modifications. The second thing is resus status. So perhaps you've got a patient that's come in and they don't have a 7-step pathway done. do not escalate that to the intern, escalate it to the resident, because the interns are not allowed to do those documents. The last one is usually family meetings or complex family matters, behavioural challenges, that kind of thing. Usually the resident is the best person to go to rather than the intern in those circumstances. And then you've got a registrar available, and that'll be variably available depending on which team you're working. And so just get a feel for the culture of your team, whether that's a registrar in a medical area where they're very much present on the ward a lot of the day and want to be involved with new issues, or whether they're more procedural based, like surgical, gastro, cardio type regs who have a lot of other responsibilities off the ward, in which case you may generally go to the resident first and then escalate to the registrar as required. So if you're dealing with really complex issues, like really complex patients that don't follow standard protocols, sometimes the registrar is the person to get involved, particularly if you've got a deteriorating patient and you feel like the intern or the resident isn't responding or maybe isn't quite meeting the patient's needs. Escalating to a registrar, or in some of those occasions calling a MET, may be the appropriate course of action to get the patient what they need in terms of care and decision making. Likewise, registrars are leaders of their teams. They're often responsible for multiple junior doctors, including residents and interns. So if you're having issues with interns or residents, you feel like there's areas they could improve on, or there's specific challenges that you're having recurrently, it's good to escalate that to your team leader or even your nurse unit manager, and then for them to have a conversation with the registrar. But myself as a registrar, I'm very happy to be approached by any nurse of any level if there are particular suggestions of how we can improve our teamwork or particular challenge that you're having with staff that I'm responsible for. So come and talk to me, and likewise most registrars would be keen to have those conversations. We want to really work together well as a multidisciplinary team. The other question to ask yourself is to say, who knows this patient really well? So sometimes certain interns or residents are very involved with particular cases, either because they're geographically related on the ward or because they're complex, and so for continuity, the same number of staff has been involved. Call them. Or if you're looking at a funny time of day, who was the staff member that saw them most recently? They're going to have that continuity of care. Maybe call them as first point of call. And those are particular situations when you've got a big general medicine or general surgery team where you've got multiple interns and residents. Who should you call? The person who knows the patient well, the person who has seen the patient most recently. So you're going to make the call. You decided, okay, I know what I want to achieve. I gathered the information that I need, and I've decided who is the person that I'm going to call first, who I think is going to be most suitable, and if they're not, they'll be able to escalate the issue or direct me otherwise. So most of these people, you're going to be paging them, and in some cases using a speed dial. So there's a bit of etiquette with phones. So if you're paging them, you should page and then wait and guard your phone so that no one else uses that. And ideally, if they don't respond, wait for 3 minutes, because you've got to consider, like yourself, a lot of these junior doctors are involved with procedures like putting in cannulas, family meetings, documenting on ward round. They will make time, hopefully, for answering your page, but they may not be able to do it within 60 seconds or 120 seconds. They may be gowned because the patient has MRSA and they're physically examining them for their shortness of breath. Give them a few minutes, and I think 3 minutes is a really safe kind of way to go. If you're paging like within 60 seconds twice, that's really can be sometimes misinterpreted as a kind of aggressive or escalating kind of response, and that's not always very collaborative. So maybe 3 minutes or so and then page. Now, if you don't get another page after that, you can then again wait another 3 to 5 minutes and call their mobile would be reasonable. And if you do call and they don't pick up, please leave a message, because I've had so many missed calls from unknown numbers and I don't know who to get back to, because maybe my pager, I don't have a pager, or my pager's malfunctioning and there's no room. So even if you just say your name, where you're from, and ideally an extension number, that doctor can get back to you hopefully. And if you're not able to get that person, well, let's escalate after 5 minutes to someone else and just repeat the process of paging or calling their speed dial. That's some of the etiquette that I think we should try and practice with each other. When you've got the phone, it's very easy to jump to the issue and say, I've got the gentleman in bed 6 with cholecystitis and his BGL is 22. What do you want me to do? And we've just missed a bunch of things. So we go back to structure that will easily and efficiently communicate the important points. So the ISBAR structure is one of the best ones. Introducing yourself, so saying, my name's John, I'm on Ward 2C. Are you the colorectal intern right now? Yes, I am. Cool. I'm just calling about Mr. Jones in bed 27, who's under colorectal, and you're just clarifying that. So don't use like conditions or just bed numbers. We really need names of the patient, and you can then back that up with a bed number just for clarity. And then the situation, I'm calling because their BGL is very high. I do notice that they are a type 2 diabetic and they're usually on insulin, and we held the insulin this morning because there was a low BGL overnight, and I just wondered what you'd like me to do. And it may be at that point they'll ask some questions and say, oh, okay, what was the BGL at this time? So having the BGL chart there, having the medication chart are going to be really handy resources for you, because then you can say, yep, they are on metformin, yes, they are on empagliflozin, but that's been held because of surgery. They're usually on 30 units of Optistulin and 10 units of NovoRapid with meals. The NovoRapid was usually held, and they've held the Optistulin, and then they can then give you an order and say, yep, I'm going to come by and chart things, or I'll give you a phone order, whatever that is. If you're armed with the information or the resources that are right there, you're going to be able to engage in that conversation and quickly come to the outcome that you're looking for, which is a management. So there's a few common mistakes that we all can make, regardless of our background, when we're calling. So like calling the wrong person, and that's why clarifying that you've called the right person early in that phone conversation. You've identified yourself, you're confirming the identity and role of that other person. And sometimes they'll say, oh, I am the colorectal intern, but I finished at midday and you're calling me at 4, I need you to call someone else. Now, it's not really appropriate for you then to say, who should I call? Because they're not paid to take this phone call. They've maybe taken it out of duty. And at that point, it's appropriate to say, no worries, I'll find out who's on and call them, have a nice evening. Likewise, we wouldn't call you when you weren't on duty, or if we did by accident, we would have no expectations that you'd be able to help us. Other common mistakes is not being armed with the information, or perhaps skipping the identity of the patient. It's easy to talk about similar patients. I even did that today, where we were talking about a preoperative review for a patient. I thought they were talking about one patient. They were actually talking about a second one. It was only at the end of the conversation where I said, can I just check what's the name of this patient? And they said a name that was different to the patient I thought, and I actually said, we're talking about different patients. Why don't you give me those details? Because I can see that we've had a bit of miscommunication here. Other things can be that you've called a person that the role is not really theirs. That perhaps a really common one is it's after 5 or 4 o'clock and the regular home team is finished for the day, and the cover team is on, and so we should be calling the cover team in those instances. Those are the kind of common mistakes that might happen. It's really important that throughout all of this communication that we keep it clear, efficient, and respectful. And I would expect that from my colleagues. I hope you would expect it from yourself and your colleagues. And if you're having challenges with maybe less than respectful and professional communication, please escalate that, because that's an issue. That's going to be a barrier to good patient care. It's going to be a barrier to a really safe working environment for us as staff members and colleagues. And no one sets out to have a bad day or to misbehave or behave in an unprofessional way. Sometimes people need a bit of encouragement. Sometimes they just need that little bit of accountability from their senior to say, are you having a tough day? I think you're a bit short with one of our colleagues. So if you're having little challenges, please escalate that to your team leader or your NUM. We'd love to have a conversation about how we can improve our collegial relations and the way that we work for better patient care. So I hope that's been helpful, and that you can then apply some of those rules that we're going to use when doing the phone call. And I'm just going to repeat, before we have the phone call, let's revisit those 3 simple questions. Number 1, what is the purpose and the desired outcome of your phone call? Number 2, what's the information or the resources you would need to be able to engage in a conversation around the issue that you're raising? And third, who is the best person to call in terms of role and the time of day? If you're answering those 3 questions, you're ready to pick up that phone and page or call the right person and get a good outcome from your patient. Thanks for listening.